Let's kick off for the moment. I'm Jenny Rydorp. I'm Interim Director of Programmes at NHS Providers, and I'm the chair for today. Really delighted to welcome you to this event. It's the latest in a series of virtual events that we're holding as part of our provider collaboration programme, which focuses on sharing emerging good practice and learning on provider collaborative hot topics, particularly for board members and programme directors, through webinars like today, through peer learning forums, through case study briefings and resources. We've got a really diverse audience on the call. I can see some people are still joining us, so welcome to those of you who are just joining the call now. And we've got a mix of executive and non-executive directors, programme directors, amongst others. And do, if you're able to introduce yourself in the chat, that would be great to help people make connections during the call. So today's focus is on provider collaboratives working with their partners at place. It's a topic that comes up a lot in our discussion with provider collaborative leaders, and we know that many of you are engaging very closely with place-based partnerships. I just looked back at a survey that we did with the NHS Confederation earlier in the year on the evolution of provider collaboratives, and in that survey it said 7 out of 10 respondents reported that their provider collaborative was meeting very regularly with place-based partners. But we all know that multiple challenges can be thrown up by navigating the complexity of the different partnership arrangements in place across systems. So it's a chance for us to zoom in today on 2 case studies and to really look at how 2 different types of collaborative and 2 different systems are overcoming those challenges and seeking to really realise the benefits and opportunities to deliver benefits for patients and service users. So the 2 case studies we're going to hear from today, firstly is going to be Kate Pett, Managing Director of the University College London Health Alliance, which is an all-in or a multi-sector provider collaborative in North East London, ICS. So many thanks to Kate for joining us. And then we're going to hear from Keir Shillaker, Programme Director of a Mental Health, Learning Disability and Autism Provider Collaborative in West Yorkshire. So thanks in advance to both of our speakers for coming along today at when we know it's such a busy time for everybody on the call. It's very much appreciated. We're going to hear from Kate first and then Keir. Do please feel free to post any comments and questions in the chat throughout, but there'll be dedicated time after each speaker for you to come in. You're very welcome to use the raise hand function or to wave your hand at that point. We'll take the slides down and I'll just bring you in. We will circulate the slides afterwards in a post-event email, so don't feel you have to scribble away unless you want to take notes. So without further ado, I'm going to hand straight on to Kate, who's going to kick us off. Thanks very much, Kate.
Thanks, Jenny. Afternoon, everybody. My name's Kate Pett. I'm the Managing Director of the UCL Health Alliance, which, as Jenny said, is an all-in collaborative. Can I move to the next slide, please? So I'm going to sort of just quickly talk you through what to expect in the next 10 to 15 minutes from me. So I'm going to talk you through who we are as the Health Alliance. I'll give you some information on North Central London, which is our ICS, and then just sort of talk about developing our relationships at place, the priorities that we have within that and the challenges that I see on a kind of regular basis, and then the benefits and ambitions, and trying to finish off with a bit of a key message about where we are going to and what we see as our kind of the benefits of being in place. So next slide, please. So the UCL Health Alliance is an all-in provider collaborative for NCL. We have 14 partners. 4 of those are acute trusts, and that includes UCLH and Royal Free. 3 are specialist trusts, including Gosh and Moorfields. 2 community trusts, and both of those community trusts have a footprint within NCL, but quite a large footprint outside NCL as well. 3 mental health trusts, the GP Provider Alliance, which is we call the GPPA, and UCL, which is our academic partner, and why we're called the UCL Health Alliance. Just for just in a conversation, what is all in? It's basically we've got representation from across our sector. So lots of the provider collaboratives are acute or community or mental health. So we are one of a few provider collaboratives that have more than one sector represented within our collaborative. From our structure, we are a limited liability company. and we are managed through a set of directors. So we have boards and committees. And that we are slightly different in our setup to other provider collaboratives, where there's some who are managed through committees in common or boards in common, and others are managed through more of a traditional kind of partnership arrangement. It's a kind of long, I'm happy to go into that in more detail. It's a long-standing kind of way we were set up, and it just helps with some of our collaboration across the system at the moment. And we're one of 9 provider collaboratives who are on the NHS England Innovator Programme, where we're looking at trying to accelerate some of the work we're doing around our priorities, and we're doing that with some support from some specific NHS England teams. Next slide, please. So continuing just on kind of who we are, our vision and objectives. So our overall vision is to reduce the variation and improve outcomes for residents in North Central London and those individuals from outside our system that draw on our services. One of the reasons that it's not a hugely ambitious thing, I think it's a really standard thing we should be doing. But what we want, as I reflected, we've got 14 partners, including some quite big names in healthcare, Gosh, Moorfields, UCLH, they're all free. One of the things that when we set ourselves up about 2.5 years ago, there was a recognition that for North Central London, having those leading health players in the system, our outcomes for residents were not necessarily as high or as good as they should be. So it's a real focus on how all of those players in our system focus down into North Central London. The Innovator Programme itself, we are specifically looking at improving the capacity and capability at the front end of the clinical pathway, really that kind of primary care, pre-primary care end, and that's really important when we're thinking about our relationships within place. Next slide, please. So North Central London, I've kind of assumed you don't know where it is and what it is, so just to give you a little bit of an overview. We have 5 boroughs in our system, Camden, Islington, Barnet, Harringay and Enfield. Geographically, we border the south of our patch goes all the way down to Oxford Street, and the north goes up to the M25. If you also want some other references, we contain both Arsenal and Tottenham football clubs and Saracens rugby clubs, so some geographical sporting landmarks for you. We have a population of 1.7 million, and we have a really high transient population. Some of that is around homelessness. So Camden has one of the highest homeless populations in London, but we also have a vast number of students. I lose count of the number of different universities and higher education facilities we have in NCL, but it is quite significant. So we do have quite a significant transient population through the year. We also have 2 major London termini. So we have Euston and King's Cross, St Pancras, which obviously contains the Eurostar. So a high number of people coming into our patch every day who are not our residents, but then choose to have their healthcare within our system. NCL, 20% of our residents live in the most deprived quintile, 36% belong to an ethnic minority, 16% have a diagnosis of at least one long-term condition, and 20% have at least one behavioural risk factor. I don't say this because I think we're any different to anywhere else, but it's just trying to help that kind of, this is the complexity of the landscape that we work in North Central London. I'm really aware that every kind of individual ICS has got its level of complexities. Next slide, please. So one of the things to think about was kind of how we've gone about trying to develop our relationships at place. So we build it on our work from individual providers. Although I'm the managing director for the UCL Health Alliance, I have a substantive role at UCLH, and part of my role at UCLH is around our partnership working, especially with our place-based partners. So it's building on that. I do a lot of that as kind of a shared bit of role across the two jobs, and quite a few of the other providers that I listed on our collaborative will also have people who can represent both the Health Alliance and also their own individual organisation. Spend a lot of time with our ICB leadership on place-based priorities and opportunities for delegation. So we've had a programme of work in our ICB. I think it's now been going on for about 14 to 15 months, looking at the kind of role of place and looking at kind of how you move from an ICS, how you think about delegation of authority, delegation of priorities, what's the driving force behind everything, and that's a continual piece of work. I mentioned our GP Provider Alliance. So our GPPA has representatives from each of our boroughs that form our GP Provider Alliance board. And those GPs are then on our local place-based partnerships. So again, they'll be doing that dual role of thinking about representing themselves as a GP within their place-based priorities, but then thinking about how they're then coordinating that as a GP response for the whole of our system. We've been working on some key work programmes within the Health Alliance. So one of the things that we're doing a lot, which fits to our Innovator programme and that bit around capacity and capability at the front end of our pathway, is identifying reasons for why people go to see GPs. So not necessarily what happens when you go to see a GP or the outcome of that appointment, but what actually drives you to pick up the phone or to log on and book that appointment, and trying to understand the kind of top 5 clinical reasons why your people in NCL are going to their GPs. And what we want to do with that is understand some influential parts of the pathway where we can support as a system and as a provider collaborative changes that would then have an impact on capacity within our primary care system and then onwards to secondary care and community services, but also definitely benefit resident and patient experience. We're working on in one of our places, so in Camden, we have a virtual ward programme. So we have a virtual ward programme everywhere, but specifically in Camden, we're trying to bring everyone together in the coming weeks to think about how we can increase our uptake and the coordination of our programme of virtual ward and how we do that across our provider landscape. And then one of the other ones, which isn't on this slide, but is something that's quite key to us, is the maturity of our clinical networks. And looking at how our clinical networks that are across long-term conditions, as well as our kind of elective recovery networks, how they're there to support a more equitable access to place level. So we're looking at things like self-referral, women's health hubs. We're looking at kind of that, is it equal access across all of our 5 places? Next slide, please. Moving into how we think about kind of operating at a place level, these are 2 of our the priorities programmes from 2 places within our system. So one has 4, very much looking at integrated front door, urgent response recovery service, locality development and mental health and care. So there are kind of high level 4 priorities for this place. One of our other places, we're looking at integrated neighbourhood teams, baselining prevention data, LTC management, involving borough partnerships and delivering our health and wellbeing priorities. So we've got 2, they are 2 quite different. There's some themes within that in terms of governance and some of how we're trying to do things and thinking about the kind of how we make things hyper-local. But those are 2 places that have quite different priorities. And then the other 3 that remain outside that will also have different priorities. So it's quite key to thinking about how we're working at a place level. Next slide, please. So that goes on to the challenges of working at place. So our 5 boroughs have different structures in each place. The 2 that I presented just now, one of those has we have an integrated care executive. So we have representation from all providers, local authority, the voluntary care sector sit on that executive. We then have local care partnership board underneath that. And it's looking at all ages, so children through to our Start Well, Live Well, Age Well kind of programmes, and it's looking at the provision from all of our providers within that system. The other one is divided into adults and children, so we have an integrated care board, which is a bit confusing in its title, but it's the integrated care board for that individual place that looks at adults, and then we have a separate one that looks at children, and they both feed up into a borough-wide place-based kind of board, which is led by our local authority and very sort of more politically driven. So they're very different structures just for those 2 boards. And across those 2 boards, we have quite a lot of overlap in terms of some of the providers. We have 4 acute providers within our system, but the location of those is quite variable. So within Camden, both the Royal Free and UCLH are physically based. UCLH and the Whittington also share Islington. The Whittington and North Middlesex share Haringey. The Royal Free is the only physical acute trust that sits in Barnet, and there are no acute trusts that sit in Enfield, although it is managed by, supported by the North Middlesex. So there's a real variability in how we sit within each of those places at an acute level. And then we have a variety of different ways about how our community and mental health trusts kind of dock into that as well. Talked about the breadth of our stakeholders in the Health Alliance to start with, so 13 different providers coming from a range of different areas. If you look UCLH, only 52% of our referrals into UCLH come from NCL. So we have a really big non-NCL population that comes into that. And that number will go down when you're looking at the specialist providers like GOSH, and also sort of Moorfields and the RNOH, so the Royal National Orthopaedic Hospital. So the breadth of stakeholders is big, and then their focus of how much of their activity comes out of NCL is variable across our different providers. And then we have a mix of priorities, and this will be the same in every ICS. So we've got the priorities at a system, the priorities at place, and then the priorities at a provider. Next slide, please. Having said that, I think there are an enormous number of benefits. The challenges are things we need to overcome, but there are an enormous number of benefits. So firstly, it's kind of, we can effectively create a manageable baseline of data, including really hyper-local patient and resident feedback, which helps us understand what we're doing at a provider level. Even if you've got a low amount of NCL activity coming into that individual provider, you can really get into the detail of what's driving that local kind of demand and our experience. Providers are working collectively to make improvements, including increasing integration to deliver care closer to home. So as I said, we're doing the piece of work around our virtual ward in Camden. And one of the things we're looking at is how UCLH and the Royal Free, who probably historically haven't been necessarily, in some of their clinical partnerships haven't been that close, how we are really starting to work together to make sure that what we're doing is looking at how Camden residents benefit and what services Camden residents need, and how we can deliver those together for our patients and residents. We build on existing relationships between providers, and some of those are developing, leaps and bounds through the place-based approach. And one of the things, they're using UCL as part of our partnership, really looking at how we improve the research offering and engagement in local areas. So how we're building on equity of access to research as well as equity of access to our healthcare. Next slide, please. So our ambitions as a health alliance is we want to work with our ICB colleagues and our place-based colleagues to look at how we have priority, joined up priority planning. So it's kind of an evolving piece that I think we'll start to see more of in the coming year to 18 months, but how we're all kind of sitting down at the point in time in the year and thinking about how it all fits together and who's doing what and how we're going to do it. For the pathways that I've mentioned, and there are quite a few that are being worked on across NCL, how we have an end-to-end pathway development plan so that it's a really joined up at a local level all the way through to a system level, and how we have clear outcome improvements for each place. So gynae is probably quite a key one for us at the moment, thinking about how we have a variety of community gynae services in NCL. Some of our boroughs don't have a community gynae service, and some of them have a really top-notch, really quick access pathway. And we're working with the ICB on how we improve that, but then going down to a place level about how we think about what systems are in place for us to work towards self-referral and health hubs. Having a key provider lead working in each place who is sitting with that dual hat of like I do, so what UCL Health Alliance for some of what they're taking in as well as their own individual provider. And like I said, clear links to our innovation and research programme, how we really benefit from everything that goes on within NCL in terms of both that academic research and our innovation opportunities. So last slide, please. So I think the key message for me is flexing across place-based priorities for multi-place providers is challenging. I often talk about how we try and fold ourselves down from being, from UCLH point of view, how we fold ourselves down from being £1 billion organisation where about half of our activity comes from NCL, really folding ourselves down into a specific neighbourhood within one of our boroughs. So what are we doing in Camden South? How are we working on Camden South and the patients and residents in Camden South, and how are we improving their access, and how are we working together as a group of providers to think about that real sort of small, sort of 40 to 50,000 people kind of in a locality. But however, I think if we can get this right and we're successful with the approach, we will deliver improved outcomes and quality outcomes for our local patients. And that was my last slide.
Thank you so much, Kate. That was a really rich presentation, and also I thought just conveyed the complexity of what you're navigating alongside the opportunities, and That was really, really powerful, and the opportunities that you're particularly focusing on early in the pathway. So thank you so much for that. I'm going to open it up for comments and questions from the chat. I've already seen a great question from Rachel Hunt. Rachel, do shout if you want to come in, and David, I've also seen your hand up, but Rachel's question was about explaining the role of the ICB in supporting your all-in provider collab. Over to you, Kate. And Rachel, do come in with a follow-up if you've got further points you want to make. Oh, and David saying that's your question as well. 2 for the price of 1. Over to you, Kate.
Yeah, so in a governance structure, our ICB are part of so they sit on our executive. So we have and they also sit on our board as well. So we have a non-executive and an executive board. The voting members are all of the directors of our provider organisations, and our ICB accountable officer, our CFO, and our 2 or 3 of the other execs are also part of that meeting. So they come and they're a real integral part of what we discuss. I then sit on, we have a ICB senior management board on the weeks that we're not meeting as an alliance exec, and I sit on that. So there's quite a joined up approach to it. Our ICB is incredibly supportive, and we are working really hard together to think about how we reduce duplication, we improve the kind of outcomes, and our ICB, like every other ICB, is going through its change program at the moment, and we're working through together what that means to us with in terms of what's going to stop from an ICB point of view, what that now means that the providers should and could take on board, and what we collectively are kind of thinking about the impact. So I think it's a really, really joined up approach that we've got with our ICB, and one that I really relish every day.
Fantastic, Kate. That's very energizing to hear such positive relationships with the ICB. David, I can see your hand is still up.
Yeah, I will follow up if that's okay. Thank you, Jenny. Thank you, Kate. Really great to see. And we obviously have a very different setup. I live in Bristol. We're in Bristol or Somerset setup, and we don't have a all-in collaborative in the way that you've just described at all. The way it feels to me is that the kind of place-based prioritization. We have place-based partnerships, but that kind of place-based work and prioritization that you've suggested, I think for us probably does come through the ICS strategy and ICB board more. My question is, what form of delegation do you have from the ICB, if any? So given they're integral to you and vice versa, have they given you any formal delegation?
Thanks, David. Great question.
But no, that's at the moment we don't. That still sits with the individual providers. It's the things that we're beginning to work through in terms of the outcome of the change program. Our ICB has decided to go through one very painful year of a change program as opposed to sort of over 2 years. So we are expecting changes to come more next year in terms of some of that conversation about delegation. We're set up that we can be delegated to, but at the moment we haven't had anything delegated down to us.
Thanks, David. Great question. And Rachel, do come in if you had any more follow-up.
I don't, but I just want to say thank you, Kate. It's really interesting to hear, and I would sort of echo David's comments about maybe being at the very beginning of the journey you've just described, and that we don't have an all-in provider collaborative. Can I ask, how long have you been operating in the current ways of working, and was it driven by your ICB, ICS colleagues, or was there much more providers naturally coming together? There was a natural way of working anyway, and that sometimes is about geography and history of partnerships.
Yeah, so the way we've been working, we've been established for just over 2 years, I think 2.5 years. I've been in post for a year, and we formed our company just about 9 months ago. And a lot of the first year before I started was a lot of the governance setup. The reason we're an all-in collaborative is a recognition from the providers within the system that we do have a phenomenal amount of resource within our system. We have, having that many providers within quite a small footprint is, although we're not, we actually are we are the smallest of the ICSs geographically within London. we probably are the most densely populated in terms of hospital and specialist providers. And there was a growing kind of recognition and understanding that our local population do not benefit as much as they should do from what we are able to deliver in North Central London. So I think it was I wasn't in post at the time, but my understanding of the initial conversations were very much a coming together of provider leadership. So our chief execs and chairs, as well as our ICS, or the kind of precursor to the ICS team at the time, to come up with a plan that would deliver better health outcomes for our residents. So neither singly driven by our ICS nor singly driven by our providers, but a really collective way of coming together to try and solve the problems. And I think our our provider collaborative has a huge amount of benefits being an all-in, and that we can leverage, some incredible things from each other. It's also really challenging that it's 14, and that includes UCL, when what we want to talk about is the health outcomes for long-term conditions in a particular part of our borough, or a particular part of our system. So Barnet and Enfield has some of our highest levels of deprivation and our highest levels of long-term condition comorbidities, and like I said, that's the one that doesn't have a kind of acute trust sitting within it. So trying to leverage how we get everything together to do something in that part of the system is tough. So some real benefits of all-in, and some challenges that I see other collaboratives who perhaps are focusing on a smaller number of things, perhaps are moving a bit further than we are, but we're quite keen to continue our all-in element.
Thank you, Kate, and thanks, Rachel, for a great question. I'm going to go to Darminda, and then Mo, I've just clocked your question in the chat on PCN, so we'll then go there next. So Darminda, do come on in.
Thanks, Jenny. Thanks for the presentation, Kate. So I work with the NHS Devon system, which geographically is, I'd say, quite neat. It was one CCG and now it's one ICB. I think just in terms of the progress we're making, it feels like we've done a lot on relationships. We feel more organised. But what would you say are your kind of best improvements or most tangible progress you've made in the last 12 months that you'd say, well, actually, this is where we've made tangible or good progress, and actually these are the areas where we're still struggling?
Great question, Darminda.
I think one of the areas that I would say we're making really good progress in is trying to knit together all the different strands that go on in ICE. So, the conversations we have about, well, how many different people are working on the same thing, and just trying to reduce some of that variation. One of the things that I think we've seen some real changes coming through in the system is we've managed to secure quite a significant amount of funding to improve our sickle cell population's health. So we've got some funding from NHS England around that, and I don't think we'd have done that if we'd have been in our kind of pre-provider collaborative days of kind of much less joined up between our providers. We're also in a much better place as a system to be having some quite challenging conversations about how we want to change the financial system architecture around how we want, so we're doing some work around our musculoskeletal pathways and some of our long-term condition pathways, where we are now beginning to work together as a system on how does the future funding flow for this. And it could well be that we are we'll reallocate growth funding, or we'll be looking to remove funding from certain organisations to put it in different places. And those conversations feel a lot more comfortable than I think they've ever felt before, because there's a huge amount of trust that we are working in partnership. So they are perhaps less tangible than we've changed this yet, but I think those are the real precursors to we are going to see some substantial changes in NCL.
Great answer, Kate. Thank you, Darminda. That's a powerful question, because it's the one on everybody's minds, isn't it? About where are we all on realising benefits. I'm going to go to Mo about how easy it was, Kate, to engage with PCNs in your patch.
Thank you, Kate, for that great presentation. I think one of the biggest challenges, if we're going to really deliver care close to patients' homes, would be joint working with primary care networks and GP practices. And if they're not I mean, it's always been a challenge from good old days of primary care networks or PCGs and stuff. Just wondering how you've engaged them and how you got them involved and got the buy-in from them. Thank you.
Yeah, that's really led through the GP Provider Alliance and the kind of links that they have. So the GPs, as we were developing the UCL Health Alliance as an entirety, the ICB sort of supported the GPs to come together in a similar kind of GP Provider Alliance. And so each of the boroughs and each of the PCNs, so we have the PCN clinical directors, are part of that structure. So either that they feed in through their own borough structure, and then there's borough representation at the GP Provider Alliance board. We have GP Federation leads within that as well. So that GP leadership is so key to what we're trying to get done, which means that when we're talking about things at place, we are really comfortable about talking, like I said, we'll be talking about the south of Camden and or the middle of Camden, or and we can do that because our PCN leadership is comfortable. That doesn't mean it's all brilliant, because we have 156 GP practices in NCL, and most of those are in a PCN. I think there's a couple that aren't, but most of them are, and most of them are fairly equal. But yeah, that GP leadership is absolutely key to getting things done. And I work on a weekly basis with we have a chief exec and a chair of that GP Provider Alliance. So the chair is is the GP, and the chief exec is a director, so a non-clinician, and we work really closely to think about what we want to do as a system we can support the GPs, and also what's coming out of the GPs that we can kind of help feed in. So I think that's quite a key piece for us.
Okay, thanks so much. Thank you.
Good question, Mo. I'm just going to keep an eye on the chat if anybody else wants to come in at this point. Check I'm not missing anybody. Don't think so. I mean, I've got a ton of questions, Kate, but what I think I'm going to do is throw to Keir, just so that we make sure we've got time for you both. And then perhaps if people have got other questions on your presentation, we can loop back into that at the end. So thank you so much for what you've shared, Kate. It's really impressive about the kind of level of relationship building and the kind of change you're driving across that number of trusts and stakeholders. So just handing over to Keir to hear a different perspective. This is not an all-in provider collab in West Yorkshire. So over to you, Keir.
Thanks, Jenny, and hi, everyone. Yes, so my name is Keir. I'm the Programme Director for our Mental Health, Learning Disability and Autism Collaborative in West Yorkshire, which also covers a wider programme of work for the same sector in West Yorkshire. So next slide, please. Thanks. I'm just going to describe a little bit about what the collaborative looks like and how it kind of fits in. So essentially our West Yorkshire system is comprised of 5 places. So we've got Bradford, Calderdale, Kirklees, Leeds and Wakefield are our 5 places, and they all comprise our integrated care board and our ICS structure in West Yorkshire, and they are coterminous with their local authorities. So our ICB places are coterminous with their local authority boundaries. And within West Yorkshire, we've got 4 trusts, or 4 NHS trusts who provide mental health, LD and autism services. So 2 based in Leeds, 1 in Bradford, and 1 that covers the south of our patch, which is Wakefield, Calderdale and Kirklees. So what our role is as a collaborative, so we are employed by one of our mental health trusts on behalf of all of our mental health trusts and on behalf of the ICB to undertake work at a West Yorkshire level. So that diagram there, it basically says the mental health core team in the grey box serves the trusts, it serves the ICB and it serves the ICS. So we're really clear that we have a role supporting the collaborative, but we also have a role supporting those who are formally outside of the collaborative, like BCSE partners, local authorities, primary care, anything to do with the mental health, learning disability and autism space across West Yorkshire. And really, really key is that lovely bit in red at the bottom for us, which is about how we are organisationally agnostic in the role that we play. So we try and support everybody equally. We're trying to be the glue that stitches things together. We're trying not to take sides in kind of how decisions are taken, and which organisation ends up providing something is not a kind of a focus for us. The bit on the right basically tries to describe the slight split we've got. So when we say that we support the collaborative and we say we support the wider ICB work, so there are grey areas within this, but actually we try and chunk it up a little bit. So the the role of the collaborative tends to be focused on either the formal accountability that's been given by NHS England. So in mental health, that's often around the specialised services that have been delegated, and those who work in the sector will recognise some of those, like Adult Secure and Adult Eating Disorders and Children and Young People's Mental Health. But also it covers some of the areas of work that we're hoping, which comes to one of the previous questions, over time, the ICB will formally delegate responsibilities to the collaborative for, which used to be CCG commissioned and a kind of ICB commission now. So one of those is the work we do on assessment and treatment units for people with a learning disability. So the collaborative is formally accountable through a lead provider arrangement for those elements of provision. We as a core team sit between that and then a wider West Yorkshire programme of work, which is at the bottom, which is basically how we bring together all partners across West Yorkshire on work on learning disability, children's mental health, adults mental health, community mental health transformation, neurodiversity, etc. So we try and hold the ring on both bits, really. So kind of the interaction with our wider partners and the role specifically that the collaborative is accountable for and has been delegated some responsibility for. We'll go on to the next slide, please. So what I thought I'd try and focus on then is about kind of that element of the collaborative and our relationships with place and our kind of partnership arrangements. So each of our 4 trusts within the collaborative sit within their local place, and they have good, well-established relationships with their local place. And that means that if I take, for example, colleagues in Bradford District Care Trust, representatives from Bradford District Care Trust will sit on their local place-based population health board for mental health, learning disability and autism, and will often be in the chair of discussions around those priorities, and will be driving Bradford priorities for mental health, learning disability and autism, and will have the relationships locally with local authorities, with commissioners, etc. So what we don't do is duplicate those arrangements. They happen in each of our 5 places with our kind of constituent members. What we try and do from a West Yorkshire collaborative point of view is create those forums and opportunities when each of our 5 places or each of our 4 trusts has said, actually, you know what, there's something we want to do together here. And that becomes an area of work whereby then we get involved from our West Yorkshire core team point of view, which links to that bit in bold, really. So we only do work at a West Yorkshire level if it has the support of our places and or there is a real explicit NHS England expectation that this has got to be a West Yorkshire response and isn't something that happens in our places. And the reason for that is our ICB operating model, and it's reflected in how we work as a collaborative, is that the vast majority of funding, the vast majority of decisions that get taken still happen in each of those 5 places. And actually kind of that we need a real kind of understanding and reason for why we would do something at a bigger scale than that, because we're one of the bigger kind of ICBs and systems, and it would be kind of unwieldy from a kind of getting to our local population point of view to do that all at a West Yorkshire level. So then I wanted to briefly mention some of the kind of the formal and informal channels that we've got as a collaborative. So one thing I haven't put on the slide, which I will mention at this top, is we do have a committees in common arrangement for the collaborative. So Kate talked about kind of the arrangement they've got for their collaborative. Ours is a committees in common, so that the 4 trusts do come together formally, but that committee is a subcommittee of those 4 boards. It doesn't sit above the boards in any way, shape or form. It's absolutely a subcommittee of those boards. And that committee takes decisions about things that are specifically related to the collaborative, and generally doesn't get into the territory of conversations about place, because that is just about the stuff that they've already agreed to do at a West Yorkshire level. What we do then have is, from a formal point of view, we have a West Yorkshire Mental Health, Learning Disability and Autism Partnership Board at West Yorkshire level. So that will have on it representations from each of the trusts from a mental health point of view. It will have each of our 5 places represented around that table, and there'll be a decision maker from each of the places that is there with a kind of a voting right to say, do we progress with this particular piece of work or do we not? And we'll also have a voluntary and community sector organisation from each of our 5 places on that partnership board arrangement as well. And really, it could be argued that we don't term it in this way, that the collaborative is the driving force for the fact that that partnership board happens. And as a result of the collaborative existing, we've been able to kind of port across those existing arrangements into the fact that this partnership board now fulfills a function for the wider ICB, rather than just a collaborative in and of itself. We then have a range of work streams that partnership board is discharging on behalf of the system. And senior responsible owners for each of those work streams are drawn from across West Yorkshire. So some of them will be execs from our trusts who are part of the collaborative. Some of them will be local authority senior folks. There'll be chief execs of BCSE organisations. What we're trying to do is make sure that the West Yorkshire function and the role that we provide as a collaborative is a stitching together bit, but the leadership and the drive and the energy and the accountability sits with places and system equally. It isn't that something's been imposed upon places from the system. And then we also have a specialised services board, which covers that first box of stuff I talked about on the first slide. It covers those bits where the collaborative itself is actually formally accountable for delivering those services. So it has that link back into the committees in common. And then informally, to kind of keep the relationship strong, there's an awful lot of informal touch points we have just for the mental health trust. So we have a weekly mutual aid conversation between the chief operating officers. We have monthly directors of forum, the director of finance forums, deputy directors of nursing forums. We have workforce forums for the HRDs to come together. So we have the mechanisms by which good practices shared or challenges are shared and talked about within the collaborative itself. But then going into the wider partnership arrangements, we also have a monthly commissioners forum. So each of our 5 place-based commissioners come together to talk about their challenges, also to identify whether they think there's something we could be doing once across West Yorkshire that they're all grappling with. And that kind of flows up into the partnership board arrangements. And similarly, we have a VCSE sector reference forum from a West Yorkshire perspective as well, where the VCSE sector can talk about the challenges they've got and how they want to feed into kind of West Yorkshire wide work too. So kind of a mixture really of the formal and the informal stuff. Next slide, please. So then in terms of challenges and impact, and some of these, Kate was talking about as well, really. So one of the big challenges we feel we have, and that's possibly a scale thing as well, is about how do we get the right communication between collaborative to place and between place to collaborative. So when we're talking about some of the services that are provided on a kind of a do-once level across West Yorkshire, some of the tensions come in when individual places feel that there are individuals falling through the gaps. So there might be a particular kind of criteria for admission in a particular specialist service at a West Yorkshire level. There may be a set of services that a particular place is providing, but there may be a whole host of stuff in the middle that neither the collaborative is doing or the place is doing, and there's tension that's created as a result of the fact that there are gaps that exist. So what we are trying to do is understand what those gaps are and how we can bridge them together where possible, and where that kind of funding and investment needs to come from. There's classic issues around if there is one particular bit of the system that is providing a service across West Yorkshire, do people who live in that place get better access? So if there's a Leeds-based service, such as the inpatient service for children and young people, which covers the entirety of West Yorkshire, do more young people from Leeds get access to that service than they do in Bradford or they do in Wakefield? And to try and understand those sorts of challenges. And a really interesting one is just stuff across West Yorkshire just take too long. Is it too slow to kind of drive action when we need it to? So sometimes kind of the places go it alone. Again, kind of some of the challenges in terms of the wider West Yorkshire programme in place is about, well, who represents who? You can't necessarily have, when you've got 5 places and a big work programme across West Yorkshire, an expectation that everybody from every single place can always come, particularly for one of our providers who they actually provide services across 3 of our places in our ICB and 1 place in another ICB. How do you make sure that everybody can be represented and take decisions and be kind of actively involved? A classic one is we've got 5 places. What if 4 of them want to do something and 1 doesn't? What happens then? How do we kind of drive that conversation? Do we do that at West Yorkshire level or not? And we're trying to get a little bit more sophisticated in terms of how funding's allocated. So a lot is focused on kind of fair shares allocation going to individual places and providers, but do we need a bit more intelligence about who gets what and why that we're trying to work on? And then in terms of the impact, which might help with one of the questions that came up earlier on, we feel that working collaboratively is helping us have some influence. It's helping us have some influence with NHS England sometimes. So the recent challenge around adopting NHS 111 mental health first, we've had some really detailed conversations as a system about the impact that will have on our service users. But through working collaboratively and working well with NHS England, be able to say these are our concerns and actually help to influence some of the the national policy around 111. The ability for scale is a real opportunity. So we're developing a collaborative bank between our mental health trusts, so people can pick up shifts in the different organisations, non-medical bank, which they weren't able to do previously. Hoping that we can reduce some of our agency usage as a result. We've set up a dedicated children's and young people's crisis line across West Yorkshire, working with the VCSE sector. Again, kind of having those forums to debate that stuff has allowed that to happen a lot easier than it would have done otherwise. And we're in a really good position to be sharing some of that best practice, and Kate talked about this as well. So when we're looking at what are our individual organisations and places doing to support discharge from mental health inpatient facilities, how do we learn from one another? What are we doing to make sure that from a perinatal mental health point of view, our access and understanding about inequalities is as strong as it can be, and we're making a difference? And similarly, when we've taken the decision to do something once across West Yorkshire, seeing some of the benefit of having those collective agreements. So we've set up something called the Complex Rehabilitation Enhanced Support Team across the system, which didn't exist a few years ago, and is starting to really have an impact in terms of the number of people who are being placed out of area for rehab, and to improve the kind of the general flow of individuals who have got really kind of complex needs. And also back to the influence and stuff as well, working collaboratively allowed us to have influence within the ICB. That means that our ICB is one of the few in the country that have been able to confirm we are continuing our staff mental health and wellbeing hub offer across the entirety of the system, because the ICB is committed to fund that, because we've been able to make a case for the benefit we think we can provide, and the benefit we can provide not just to NHS staff, but to care staff and the VCSE sector as well. So recognising that kind of wider partnership piece. And then next slide, please. And then, so yeah, key learning bits. It's a tricky juggling act with all this stuff, as kind of Kate said, being in the middle of, being in the middle of the trust, the places, the ICB, the ICS and all the partners. But we're in a very kind of unique position to try and help those relationships work. It does mean that people who work in these roles need to really understand complexity and ambiguity, but be able to simplify that for others. And really importantly for us, we've got to be approachable. We've got to be the ones that we get our legitimacy from the fact that people want us to be here. If we're adding no value and they don't want us to be here, then we're no use to anyone. So we've got to be able to continually ask the question, are we helping? Can we do this? Is there anything more we can do to help you as places, to help you as organisations? That's a really important thing for us. We probably do need better mutual accountability between places and the system on some of that delivery stuff. So when we've got a specialist inpatient service for eating disorders, and we've got different types of community provision for eating disorders, and people are falling through the gaps, how do we get the joint work to make sure that we pick up those gaps? Because that is happening, and we kind of sometimes struggle to bridge that divide. We can't always rely on kind of presuming that people hear the message or hear something. Again, it comes back to involving everybody, and you can't involve everybody all the time. So the cascade of information, when you tell somebody hears a thing and the expectation they take it back to their place and they're back to their organisation and it will filter through, doesn't always happen. Repetition can be key to landing messages. So we've got this really tricky balance between repeating so it's heard and not duplicating so it's annoying. That's kind of a really tricky one to kind of maintain. And then final few things to say. Lots of things start and not all of it makes it through to fruition. People have ideas and go, actually, should we do this at a West Yorkshire level? You have to do a lot of work to figure out the answer to that question, and that doesn't mean that the answer is always yes. So it can be kind of some lost work in getting to that point. We also need to be really clear when we get out of the way. It's actually because there's sometimes a presumption that, particularly when stuff comes from the top down, that, oh, let's do this at West Yorkshire, and this is, these will be the people who sort it. Well, not always. Sometimes we need to be really clear that actually the most useful thing we can do is not get involved, and that's sometimes a brave thing to do. And then finally, there's real power in collaboration, and we're seeing that. We think between our partners, we hope we're making a difference and adding an impact, but that's not an end in itself. And one of the things we're really coming a cropper with sometimes is, people want to collaborate, they want to share, they want to learn from others, but unless the places and the providers locally have got the capacity and the capability to grab that and do something with it, we're kind of on a bit of a hiding to nothing sometimes as well. And we know there's just not that capacity, transformation capacity locally too. So one of the pleas we keep making now is, we're quite set with the structure we've got from a West Yorkshire collaborative point of view. Where we need the resource really is in place and providers to grab that and do it. We don't need more of us necessarily stitching things together. We need more capacity locally to do the change really. But I'll stop there because I'm conscious I've whizzed through a lot.
Fantastic, Keir. Thank you so much for that. Absolutely bang on time and so much rich insight and learning from your patch. Just looking at the chat and whether anybody wants to come in. I've got, again, lots of questions that I'd like to ask on the back of that, but let me just throw it out. Josh, come on in.
Thanks, Jenny. And thanks, Keir. Really interesting discussion. So I'm the policy advisor at NHS providers for place and primary care. So lots of interesting food for thought in both presentations so far. Just a question, really. I kind of was really struck by the point around subsidiarity that you were making and having the decisions made at the lowest possible level, and then the collaborative almost acting as a layer in between kind of the system or the national level and the places in as an arena or an area where activity might take place. So I just wondered whether you had any examples of work that had come from the bottom up, where places had said, we can't do this by ourselves, or it needs to be done at West Yorkshire level, against stuff that has come down from national.
Okay. Yeah, so thanks. So a really good example is probably the work we're doing on neurodiversity at the minute. So a recognition that each of our places got to a point whereby, you know, waiting lists are too long for autism and ADHD diagnosis. The support isn't there for people either, and for a number of years each place was content with trying to just figure out what they could do individually on that. And actually it reached a bit of a boiling point a couple of years ago where they said, we can't do this on our own anymore, and we need to start looking at this more as a system. And that's led to us trying to, well, do a deep dive into the issues with neurodiversity, and that's why we're trying now to create consistent commissioning framework across West Yorkshire that covers all 5 places, why we're trying to understand the impact of the right to choose agenda consistently across all 5 places, creating consistent quality standards where we possibly can do, and at the same time still allowing is the wrong word, but each place is still doing their own local innovation to try and improve kind of the assessment and the diagnostic pathways, but how we grab that, share that, and make sure that kind of everyone's learning from one another. So that's an example of something that's gained traction from kind of the needs of places. Whereas I think some of the top-down stuff might be, for example, what the expectation is on the system to respond to the fact that in West Yorkshire we still have high numbers of out-of-area placements compared to other areas. So NHS England's pushing and saying, what are you doing West Yorkshire as a result of out-of-area placements, or what are you doing in response to the discharge challenge? So the way we have to kind of feel that is to still make sure we're taking the same approach. Really, actually, the expertise and the understanding still rests within our providers, still rests within our places. But is there an additional layer of usefulness of either stitching together or of consistent kind of working that we can do on things like kind of discharge challenge arrangements that is going to be useful to the system? So yeah, when everything we're kind of described on that first slide, it comes back to that thing of predominantly. And we do try and hold to this line as much as we can do. Predominantly, everything we are trying to do is because the places want us there to do it. And we hold more of a line with NHS England saying that's not for us to do at West Yorkshire level, where unless it has to be that way.
Great answer. Thanks, Keir and Josh. Really good question. I had a question to you, Keir, but also back to Kate, just about relationships with local government. And I know in the West Yorkshire patch, you've got very kind of well-established places with clear identity, but I wonder if you could say a bit about how you've really worked at those relationships, so that it's really genuinely seen as a kind of equal partnership and not just about kind of health and care, NHS services.
Yeah, okay, so I'll start and then I'll hand over to Kate then.
Yeah, that's great.
It's a tricky one, it's honest, because for exactly the reasons that you described, in that the 5 places with their 5 really clear identities means that the local authority relationship to its place is really strong. And actually, again, with the principles of subsidiarity, most of the conversation needs to take place at that place level. So Bradford local authority with Bradford District Care Trust, with Bradford Teaching Hospitals, about kind of the arrangements they have. What we have been able to do is try and make sure that we do have kind of a local authority rep on our partnership board from a West Yorkshire perspective, who is there to try and represent the directors of adult social services and can try and bring together, if we need a wider conversation, We are doing pieces of work like a housing needs assessment that tries to understand in the next decade, what do we think the supported accommodation needs are going to be for people with learning disabilities, people with mental health. Doing that once, but then finding a way to go back to individual places and individual local authority structures to have those kind of conversations. And then if you look at our wider ICB arrangements, local authority is at least very, very present in our partnership board arrangement that's still chaired by a councillor from one of our local authorities for the wider partnership board, not the mental health one, but the wider ICB, ICS partnership board. And we do have local authority chief execs on the ICB board. But I'd be lying if I said it's not a struggle to understand what when we're talking about something at a system level, how do we have that conversation with 5 local authorities in the same way that we struggle with the engagement with primary care? How do we have that conversation with umpteen primary care networks? We can have the conversation with Richard Vaughtry, who's kind of the West Yorkshire primary care rep, but that's not enough. So we've had to build some relationship with the LMCs from a primary care point of view. We're having to pick and choose particular topics whereby we need to engage local authorities on. So which of those kind of work streams are ones where we absolutely need local authorities to come together on? But we've by no means got that cracked as a really kind of functioning, routine way of engagement, I don't think.
Yeah, it's really helpful. Thanks for the honesty on that one, Keir. And Kate, any reflections from your patch?
I'd probably just take out the phrase West Yorkshire and put in North Central London. I don't think it's that much different. And we've got 5 local authorities. And like I said, our structures are slightly different in each of our places. We do have at an ICB level, really good engagement with local authorities in our ICB and our ICP. I think when that comes down to each individual place, it probably is variable depending on which place we're in and how that relationships are. The 2 that I sit in, I think there are some really, really strong connected relationships with the local authority in its broadest sense, both that political as well as the kind of the social kind of care element of it. And in the other one, I would say it's not as well connected. And that's, I think we're all working on why, but it is variable across each place. But at a system level, I think it's quite well connected.
Yeah, really helpful. Thank you, Kate. I know that some people need to be leaving for a 2 o'clock meeting, so do feel free to just duck out, but we'll just make the most of having a little bit more time to take questions. So Darminder, do come on in.
Thanks, Jenny. Great presentation, Keir. I think you packed a lot in there, and I'm sure that there'll be lots of people on the call that'll be recognising some of those dynamics. So I know that West Yorkshire are quite advanced in terms of forming provider collaboratives. I know Wyatt have got a strong acute collaborative and again, held in high regard. So lots of history of collaboration. I was interested in the organisationally agnostic approach. And does that hinder you in any way when you're saying, well, actually, delegate this to us because we're really well placed to do this, but the trusts might be willing to hold on to it, or the ICB is holding on to something that you think actually that should be delegated to us? Because you're agnostic, no one's really fighting your corner. So have you got any things that you want to have delegated to you that you say, you know what, we'd do a brilliant job at this?
It's a really good question. And actually kind of the use of the phrase organisationally agnostic is more about the role we play between the constituent parts of our collaborative and of the partnership, if that makes sense. So what we in no way, shape or form ever want to do and can't do is favour Leeds and York partnership over Bradford District Care Trust or over Swift or kind of over VCC partners. But the point around there are things that we think do make more sense to delegate to the collaborative in some form through a lead provider arrangement. We are increasingly clear about that. So kind of, for example, the fact that we are, like many systems, kind of undertaking developments around maternal mental health services. There was an option with maternal mental health services. We could have gone, throw that money 5 ways to each of the 5 places and let them get on with it. Now that's been one where instead we've reached a consensus with people that we need to do that once across West Yorkshire, and we're going to do it once across West Yorkshire. And ultimately, when all the mechanisms allow us, we'll delegate that to a lead provider and oversee it through our provider collaborative infrastructure. The same will be through the staff mental health and wellbeing hub. At the same for kind of ATU, it might be the same for complex rehab. So there's those kind of layers happening, and at the same time as well, the reverse is happening. So we're having conversations around host commissioner arrangements for kind of independent sector learning disability provision in the patch. And one of the questions is that used to take place in each of the 5 places. They'd be responsible for the independent sector provision in each of their 5 places. Question 1 is, do we do that across West Yorkshire? If that is a yes, question 2 becomes, and then is there a role for the provider collaborative in overseeing that independent sector? And we're thinking there might be, we're just not convinced we have got the infrastructure, the capacity to do it yet. So the conversation we have the ICB is, we're willing to, but we want the resource to be able to do it and do it well.
Yeah, and I think it's a similar issue with delegation to place as it is to delegation to provider collaboratives. I think there is appetite to take it on, but with the ICB struggling with their own running cost challenge and restructuring, they don't have the luxury or the clarity of what and who can be delegated. And that's where, I guess my question to Kate earlier is, sometimes that's where those delays come in and you feel like you can make more progress, but you're being held back.
Yeah, important reflection, Dominda. And I do just know that I think that NHSE shortly will be producing some updated guidance on delegations, just on some of the piece where there's areas that need, where it's needs teasing out. So I think that is forthcoming, but I know, as you're saying, that's not actually the main blocker. It's the number of distractions and some of the challenges for ICBs taking cost out. Thanks for another good question, Dominda. Just checking if anybody else wants to come in just before we wrap up. I mean, I did just have one question that I wanted to ask you both about. I'm thinking that we've got some non-execs on the call as well as execs and those just working into the board. How you've ensured that your boards are cited on this work, particularly non-execs, when you're kind of navigating all these different stakeholders. How do you keep the whole board informed, cited, able to seek assurance on progress and the benefits that you're realizing, the risks you're managing? So Kate, to you first.
Yeah, so I think I described our structure. We have an executive and a non-executive board. So execs I meet every month, and our non-execs we meet every quarter. So we give them updates at that point, and we'll kind of have regular dialogue through those areas. The other thing I do on a kind of also a quarterly basis, but it kind of is a slightly different it fits on slightly different dates to when I meet the non-execs, is I meet the governance leads of each of our organisations, as well as and members of the governance kind of structures within the ICS. And I just give them an update of what we're up to. And what we found is that's quite a helpful way of them then feeding that back into their chairs and kind of having that non-exec discussion that way. And we provide a quarterly update that goes to our provider boards. So it's there. I think we've got some non-execs that are really engaged and probably will have conversations with in between those quarterly updates, and others that are, they were quite happy just to receive it quarterly. So we do it through the chairs of the organisation, and then that cascades down to the rest of the non-execs that way.
Super helpful. Thanks, Kate. And what about in your patch, Keir?
Yeah, so not too dissimilar. So I mentioned we've got the committees in common of the collaborative, which is chaired by one of the chairs from the trust on a rotating basis. They swap every couple of years or so. And that meets quarterly, and we always make sure there's what we call a AAA report. So our alert, assure, advise report goes from that committee to each of the trust boards once it's met, so they get the summary of what was discussed in that particular forum and what the kind of the challenges are. And then the two other main things are, we always kind of take up the periodic invites just to go to trust boards if they want us to, from a kind of a core team point of view, and talk about the collaborative and what we're up to. And then something we generally do every 6 months, so sometimes it slips by the wayside by a couple of months. We do have what we call our NED and Governor event, so kind of a 6-monthly event whereby we talk to all the NEDs and all the governors of the trust about the work of the programme. And we've got the next one in December actually, but this time we're wrapping it up in our neurodiversity summit, so having a particular focus on the challenge around neurodiversity, and rather than having a separate event, we thought it'd be a good idea to bring the NEDs and governors in focused around that. But we've covered a few things in those events before about not just the work of the programme, but also things like, what is the ICB? What's its operating model? What are all these changes in the infrastructure in the world around you that are kind of impacting on what we do? So yeah, just a few different things we try and do.
Really helpful. Thank you, Keir. So if there aren't more questions, I'm going to see if I can give people 5 minutes back. People either had an early lunch or maybe waiting to have lunch now. We haven't been multitasking during today's session. But I'd like to really thank Keir and Kate. Thank you both so much for really rich presentations. There's so much, I think, for everybody to take away from what you've shared. And I think that's reflected in the comments in the chat. So thanks from all of us. Do please put any comments and feedback in the chat about topics you'd like the programme to focus on in future, or any comments from today. We're also going to post a link into the chat to an evaluation form. It's really, really helpful to have your feedback, because the whole point of the programme is to really meet member needs. So super helpful if you could just take a minute to complete that form. Just in terms of what we've got coming up on the kind of programme ahead, we have a peer learning forum, which is for directors of strategy and programme directors. And the next one is on the 18th of October. No, sorry, I think I've got that date wrong, team. Let me just check on that one. It's we've got is it 6th of October? Yes, 6th of October. There we go in the screen. And then we have got a programme on shared approaches to improvement across provider collabs, really thinking about how you hardwire equity from the outset. And the next in those series of events is on October the 18th. But as I said, really keen to pick up on your hot topics. So do post those into the chat and we will circulate the presentations. Just kind of noticing some comments about organisationally agnostic being phrase of the day. I think Keir and Kate, you've done a fantastic job of just really highlighting the kind of tricky juggling act, Keir, I think, with your words. I think everyone on the call will recognise and having to cope with a lot of complexity and ambiguity, but the need to simplify the roles that you're doing. But I think you've also given us real sense of the opportunity for whole pathway improvement to address unwarranted variations in care, bring care closer to home, and some of those kind of conversations that are also just starting to happen around funding flows and what might be some of the kind of changes to the underpinning plumbing and wiring and funding needed to continue to drive this work. But really inspirational stuff from both of you on the how you're navigating that complexity and building those relationships to really drive impact. So thank you again to both of you, and look forward to seeing you all on future events. But thank you very much for your time today, and glad I've been able to give you a few minutes back before you go off to your next meeting. But thanks all.